Hi guys, welcome back to my channel. My name is Alicia, my channel and cover everything related to midwifery. So today I'm going to be talking about induction of labor. This video is important for you if you are a midwife in the UK basically, because significance of percent of deliveries in the UK start with induction of labor, with induction. If you are a lady, if you are a woman in the UK, this video is also important for you, as I'm going to be talking about what you need to expect when you go for induction and what questions you can ask as well as a lady when they ask you, when the media asks you, do you have any question for me? Please don't, they always say, no, nothing for now. They are really anxious. They want us to start the induction. Plus, please, whenever the midwife asks you, do you have any questions for us or for me? Try to ask questions. So in this video, I'm going to be talking about everything regarding this. If this looks like what you are interested in, please kindly stick around, watch this video to the end, and also forget to subscribe to my channel, especially if you are a woman. Yes, 99.9% of my subscribers are women, so I really talk to women. So, and I know we have lots of women in this world. Please keep sharing my videos to people and let people subscribe. Convince your friends to subscribe to my channel, please, please, please. To all my returning subscribers, thank you for always coming to my channel. Thank you for subscribing to my channel. I really appreciate you for subscribing. So today I'm talking about induction of labor. Induction of labor is like termination of pregnancy, basically, when the baby is old enough to live. So induction of labor can happen for several reasons, and most of the time the obstetrician or the midwife make the decision to induce the lady, basically. So there are several reasons to be induced. There are several reasons we may want to end the pregnancy. Number one reason is that the baby is old enough to come out. The baby has passed its due days, like post-day season. Baby is more than 40 weeks. 40 weeks is, date. So anything above 40 weeks is post-date, basically. So we don't want pregnancy to exceed 42 weeks for any reason. So in most trusts, they start induction of labor for post-day season at 41 weeks plus 2 days, 41 weeks plus 3 days, or 41 weeks, depending on whatever risk factor the lady has. In substitution, we induce pregnancy for GDM, that's gestational diabetes. We also reduce pregnancy, induce labor in case of when the baby is term and the lady has been reported, reduce fetal movement, and she's had like second or third episode after the baby is term. So we may start induction. If the baby is not really going well on a growth scan and baby is not really going well, that's staying in there is not beneficial for the baby, they must decide to induce for that reason. If there's what they call obstetric cholecysis, so if the lady have to, the woman have that, they induce as well. If there is severe PRH or PRH, only PRH as well, they induce for that reason. Preeclampsia, they make an induction for that reason as well. GDM have said that before. Any other comorbidities in pregnancy, they actually induce for that. GDM on diet, they induce at 40 weeks in my trust, basically. GDM on metformin, insulin, and all of that, they induce from 38 weeks. Your baby is term and, from 37 weeks. So from 37 weeks and above, they can induce labor for any reason, basically. So, and the decision for induction will be made by your midwife or your your obstetrician or managing consultant, and also depends on what the policy is in your trust or in the hospital you are using. So when the decision for induction has been made and now you're going to be induced, what are the things that we really use for induction? Significant percent of trust, I think, is more of national policy in the UK. They use prostaglandins, which is the Propes, the prostin and the oxytocin and mechanical method. They use all of that in combination to get you in labor, basically. And most of the time, we do induction just because your labor have not started, you're not contracting, and we want you to start doing something so the baby can come out. So when we want to the process, what they use basically, let me just speak for my trust. And I think if you are going trying to get job in the UK in the NHS, and you're at the stage of attending interviews, you may need to pay attention to this part as well, as I have had one questions regarding induction of labor before doing my interview, my job search um, process. So they use the propels, the prostin, and the mechanical method and oxytocin, everything combined together depending on how you are progressing or how you are responding to the induction agent. So most of the time we start with propels. Propels is a pessary, is the pessary that is put into the vagina, and you have to stay there for 24 hours. So the process now, the process, the first thing we do is to do a vaginal examination, and we assess the Bishop score. So most of the time, Bishop score is just, as a midwife, you know what the Bishop score is. What we do to, to assess the favorability of the service for induction of labor. So they give the profiles to make the service favorable. So you give the profiles regardless of wherever the Bishop score is. Highest score for Bishop score is actually 15, and the lowest is 0. So in most situations we give, especially for primary, Bishop score is usually 0 where we start induction. But it can vary anyway, so you can check what the Bishop score is online. And if you want me to talk about Bishop score, you can put that in the comment section. I'm going to do a video on it if you want it. So after assessing, doing a vaginal examination, then you try to put the propers in. The propers needs to go in as long as possible. Basically, you get seat to the posterior furnace of the cervix. Yes, the posterior. When you get in this way, sometimes if labor has not started, cervical os is usually not that straightforward. Most of the time it's posterior. So when you get to the posterior region, you push the propers in there. When you put the propers in there, there's usually string that stays out on the lady's vagina. Basically, you have to be there for 24 hours. You can tell the lady to keep noticing the propers. Whenever she go to the toilet, she can try to feel it whether it's still there, basically, because at times it fell off. So they need to let us know when it fell off, and if it fell off, you need to find out, if do an examination, if she's really progressed, does she need it to be replaced, and all of that. So you need to really tell the lady that information. So basically, propers stay in for 24 hours. After propers, if she's not really in labor, then if the service is not dilated enough for them to be able to break her waters, then you might decide to give another agent, which is the prostin. Prostin is more like a gel, and unlike propers, prostin only stay in there like you prostin in when a lady is having prostin, you need to reassess her after 6 hours, unlike propers that needs to stay in for 24 hours basically. So when a lady had propers, after taking the propers out, whether contracting or not contracting, you need to leave her for like 6 hours before you give another agent. So after that 6 hours, you decide to give propers, prostin, 6 hours after you assess as well. And the lady must not have more than 4 milligram of prostin in 24 hours, especially for ladies with first pregnancy. So now that's just an overview of what the induction is. Then what you do regarding when you are giving the propers or prostin depends on your trust. So each trust have induction policies and what you need to do, and everything about monitoring the baby. So in most situation, you do a CTG before you put any agents into the vagina. You do a CTG monitoring, you put on those regimens and the criteria must met before you start induction. And you also need to confirm the lady is not having any form of intolerant activities, no contraction before you give propers, as there are side effects to this thing. So especially hyperstimulation of the of the uterus, there might be tachystolia and there might be tachycardia as well. Tachycardia is, baby heartbeat going more than baseline, going more than 160. Tachystolia is when the uterus is contracting more than 5 in 10 minutes, not giving the woman time to relax. So you need to really, really tell the lady about those side effects, and that reason we don't give anything when she's already having any contraction. So when you examine a lady and she's no, when you do a CTG first and there's reason you are not giving anything, maybe the lady is contracting or the CTG is not normal, you can however to do a vaginal examination. When you do vaginal examination, then you document, then you leave her for like 6 hours maximum to re-examine, do another CTG and see if she can have something. If at any point while the lady is having, has had propers or prostate, the lady is contracting, you need to really assess what the contraction is like. Put her on CTG, get to monitor the baby, even if it's like 30 minutes, see how the baby is the baby coping with the contraction, and check what the contraction looks like as well on the CTG. Don't forget the side effects of this prostaglandin of hyperstimulation. So you need to really put her on CTG if she's contracting. So if you notice there's a hyperstimulation of the uterus, tachystolia, you really need to take the propets out. Then you get the obstetrician or the consultant to prescribe, to come and have a look at the CTG and consider if the lady will be needing tabutalin. So basically, in some trusts, really, the midwife can give tabutalin. In some trusts, the midwife cannot give tabutalin. So look at what is applicable in your trust and always follow your trust policies. Tachystolic uterus is, there's risks of uterine rupture and all of that. So please take it into consideration. Whenever the lady complain of pain after you've given propers or prostate or something, put her on CTG and check what is happening. If there is, if the CTG is abnormal, please take actions. If the CTG is normal, reassure the lady and, keep an eye on her. There are more to, having the propers. Sometimes there might be, an emergency situation, maybe, the baby is having tachycardia, or there's tachystolia or all of that. Those are the common side effects of the, of the propers. I really have an horrible experience of propers a couple of days back, and I'm really working alone now. So she's delivered, and I was like, everything looks like magic. And I feel that I shouldn't have given her the propers. I spoke with my manager that that's what happened. That I think I shouldn't have given her the propers. She was like, those are the things that happen with propers. They've really experienced it before. So since I put her on CTG to what you needs to do, so I was like, huh? Less than 2 hours. She's not even 2 cm when I did the examination. I really, really need to figure out if she has laceration. I think she has perineal laceration, but I'm so sure she doesn't have cervical laceration or something, because I didn't get to, get that information that she has. I just went there. When I go into the room, the midwife that took the delivery. This happened in antenatal ward, which is not really good, because when you have delivery in antenatal ward, it slows down everything you need to do. Yeah, because we don't do all of that delivery stuff in antenatal ward, so you have to do them. So it slows down the other activities that you need to do, and there are really, really a lot of things going on in the antenatal ward already. So we really try to avoid having a delivery in the ward. So after I went there, then I have to, deliver the placenta, do everything, and he was just looking at magic. I left the ward that fateful day, some minutes to 9. It was really, really terrible. But that is that for that. That's one of the things that preppers can do. And at times, people will have preppers posting everything, nothing happened, and they say, that's failed induction basically. And when you have a failed induction, the option is either, depending on what your gestation is, either to go home and have a 1 week break and start over again next week, or to do a cesarean section. It's about that induction, but there's really, that's just an overview of what the induction process is. So as a lady, you come in, we say we're going to induce your labor, we need this labor baby to come out and all of that. You come into the antenatal ward, the midwife has explained everything for you, and now the midwife is asking you, do you have any questions? You can ask about what the pain is looks like, you can ask about contractions, what you need to do if you're having contractions, coping mechanism, pain option, what pain option do we have for you in the antenatal ward, and all of that. So sorry, what pain management option do we have for you in the antenatal ward, and what you can tell us about what your initial pain management plan is, what you plan to have in labor, if you plan to have epidural, if you plan to just use the internal Gasanel, or you plan to just use, paracetamol, you plan to just use paracetamol and codeine, or you plan to have an, petidine. You can let us know what all of that is. You can ask us about, the exercise that you can do that can help you, in this process and all of that. You can ask us what options you have basically. And another thing I need to tell you is that when you come in for induction, that's one of the aspects that you might eventually have to spend a couple of days in the hospital. So you can ask about if you can bring your meals, if they can, if there's microwave for you to, microwave your food, if what their food pattern is, what time do we start serve lunch, dinner, all of that in the NHS, in our trust basically, or in the hospital. Most of the time for us from Nigeria, Africa, and all of that, if you come as a patient and in the hospitals they're giving you 6 p.m., they're giving you your dinner by 6 p.m. It's like, mo mind only 10 p.m., 9 p.m. Now somebody is bringing my dinner by 6 p.m. It's changes. So you really need to know all of that. You can ask if you need to, basically. You can ask about, though they will have told you about the days, the estimated days that you can spend. And the most important waiting part is when you are now okay, you're ready to go to delivery, so to have your water broken. That waiting period can be really, really traumatic. Yeah, you can wait for a couple of days, and they don't really do first come first serve. We do risk assessment every time, every day. Yeah, every time, every day. So if we have anybody that is more at risk, that is high risk than you, the person will, be given priority. So all of that make you, stay longer in the world. So you may need to design ways of coping for yourself when you are in that stage, basically. So it's really traumatic. It's really, but there's nothing anybody can do about it. And another thing is that NHS is really, really overwhelming. So at times they are so staff, we will have to stop some process. So that is there's nothing anybody can do about that. So you really, really need to prepare your mind to everything eventuality when you go in for induction of labor. And as to whether induction of labor leads to cesarean section or anything, whether you have induction or you go into labor spontaneously, there's nobody that can. There's always risks of, having a cesarean section. Nobody knows what will happen. There's always, anything can always happen. So whether you have induction of labor or spontaneous labor, the risks of you likely to end up in cesarean section is still the same thing, obviously. Though I haven't really seen a research on that, but that's more it looks like, basically. It's mostly the same thing. So if you're saying, oh, because I might end up having a cesarean section, I'm not going to accept the induction of labor, I don't think there is a reason that's something that you need to do. No, it's not really significant. So that is that about induction of labor. I can remember for now. If there's one other thing you need me to say, please say that in the comment section. So as a recap for midwife, you really need to read about the induction of labor process policy in your trust. But most likely everywhere in the UK they use the PROPES, prostate, oxytocin, and ARM. So you need to know when to start, induction of labor, what to start with, and you need to have, you know an overview of the human history to know what type of agent to give. Most of the time we don't give propers to feedback. So people that have had cesarean section before, you don't give them propers. People that have their membranes ruptures from, you don't give them propers, you start from prostate. So you really need to know all of those things in your fingertips, especially if you're working in the antenatal ward as a midwife. Please read your policies, read the national policies and also your trust policies. And I wish you all the best in your trust, in your new job, and I'm sending my love to you. Thank you for always watching my video. Don't forget to share to your friends and colleagues that might benefit from this information. See you in my next video. Bye.